Bismillah. Okay, are we live now? Do you hear me? Right.
Okay.
We are almost ready now. I think we can start now. So, good evening and welcome everybody in this webinar. I would like first to thank Saudi Society for Blood and Marrow Transplant for organizing this webinar. And I also would like to thank Novartis for sponsoring it. I would like to thank both speakers and attendees for joining us tonight in this interesting webinar. The webinar will be about sickle cell disease. We have two eminent speakers. I'm so excited to start the webinar, but before we start, I would like to mention a few housekeeping remarks. The webinar is being recorded. We will start with the two lectures first and leave the questions to the end of the event. There will be a Q&A mode that will be activated by the end of the presentation. So they can't post any questions during the presentations. However, the Q&A presentation will be activated after the finish of the second presentation. So please, if you have any questions during the lecture, please write it down in a piece of paper or on your PC or mobile in order not to forget them after finishing the presentation. And when the presentation finishes, you may send it to one of the speakers. When you send the question, please end your question with the question mark because the application will automatically send any phrase with a question mark to the question side. So now let me introduce my synonym, Professor Abdullah Katla. He has been working at the Medical College of Georgia at Augusta University since 1985. He completed his residency fellowship at Istanbul University Medical School in Istanbul before joining his current position. He is a professor of medicine and the director of Center for Blood Disorders and section head of hematology, oncology, and stem cell transplant in the Department of Medicine. He has wide clinical and research experience practicing also benign hematology, and he's really an active member in the American Society of Hematology. He has over 200 original articles and 2 book chapters and 177 abstract presentation. In the coming 20 minutes, he is going to talk to us about innovative treatment for sickle cell disease. So without any further delay, I would like to invite Prof. Cutler to take over the podium. Please, Prof, go ahead.
Thank you very much. And first of all, let me begin by thanking you all and thanks for having me. It's a pleasure to be here on this platform. We can start my presentation. Okay, hopefully, yeah, okay. What I'd like to do in the next 20 minutes, hopefully, is review some of the new developments in therapy of sickle cell disease. And how, if I can, oh, here it is, all right. Now, this is a world map showing the distribution of sickle cell disease, essentially. The darker the color, the more the numbers. And as you can see, in sub-Saharan Africa and in India, the numbers are darkest, but I think it's pretty much to say that sickle cell disease now, with the population movements and immigration, has become more or less a global disease in Europe and in North and South America for a variety of reasons. Now, this map in the near future should also serve us as how to design therapeutics and where the patient populations is, essentially. I'll go over quickly. I think this audience knows this very well. Sickle cell disease is a chronic hemolytic anemia, first and foremost. And it's well known that one of its major pathophysiologic mechanism is vaso-occlusion, occlusion of the microcirculation by sickle cells or rigid cells. These phenomena lead to a chronic inflammatory state, which has become well known and established over the last 2 or 3 decades. And all of these end up in organ damage in the end. Now, this is the traditional view of sickle cell, the sickle pathophysiology. The event in the center of the pathophysiology is the sickling phenomenon. Because of the mutation in hemoglobin S, glutamic acid to valine, when the hemoglobin molecule unloads its oxygen to the tissues, there happen to be contacts between the adjacent molecules, which leads to the polymerization of deoxyhemoglobin S. And these deoxyhemoglobin S containing red cells, if they assume a sickle shape, are very dense and non-deformable. So these cells occlude the microcirculation, and also they have a short half-life, and that was the main pathophysiology. Now, over the last 3 decades, we have come to understand and recognize many what one might call downstream effects of this phenomenon. Yes, this is very important. This is the central phenomenon, of course, but there are a whole host of other events taking place that makes the disease this severe in many cases. First of all, vaso-occlusion leads to an ischemia reperfusion injury, and that activates inflammation, activating endothelial cells, increasing the expression of adhesion proteins, inflammatory cytokines. Then these cells interact with the activated endothelium and with each other, leading to activation of white cells and platelets, further adding to the inflammation. Hemolysis leads to nitric oxide scavenging, further worsening endothelial dysfunction, and also phosphatidylserine exposure activates the coagulation, platelet activation, membrane damage, lipid peroxidation, and potassium loss, red cell dehydration, which then comes to increase this phenomenon of sickling. So, in other words, all of these downstream events are intertwined and related to each other, and in the big scheme, serve to enhance the pathophysiology of sickle cell disease. This graph shows the changes in life expectancy of sickle cell patients in the United States over the last 40 to 50 years. In the 1970s, when the sickle cell programs were being started, it was in the teens, and today it's probably in the 50s in general, although there's wide variability. Now, what led to this development is shortly summarized in this slide. These are the milestones in sickle cell disease. In the United States, we learned about the natural history of sickle cell disease. This study called Cooperative Study of Sickle Cell Disease. That was followed in the 80s with the prophylactic penicillin study, which now has become a centerpiece of treatment in newborns. Then multi-center study of hydroxyurea, followed by a STOP and STOP2 trials that looked into the pathogenesis and prevention of stroke in children with sickle cell disease. This study took the use of hydroxyurea to infants, which eventually led to FDA approval recently. And then again, this was a study of hydroxyurea to decrease stroke risk. And finally, the sustained study of an anti-P-selectin antibody, which I will come back to. Now, in all of this, the therapeutic modalities that were available for sickle cell disease, I lost my screen somehow. Yeah. Number one, transfusion, which could be done either episodically when you need it, when the hemoglobin drops, when there's hypoxia, or for certain indications, chronic transfusion, especially primary and secondary prevention of strokes. Then came hydroxyurea as a hemoglobin F inducer, and this has been the cornerstone of anti-sickling therapy for the last maybe a good 20, 25 years. And then in the meantime, we still do symptomatic management of pain with opioids and other analgesics, IV fluid therapy, and then for the last maybe almost 40 years, stem cell transplantation, which I'm sure we'll hear from Dr. Al-Zahari, has been the only curative approach. So why is hemoglobin F induction? Simply to remind everybody that hemoglobin F induction is beneficial both in sickle cell disease and beta thalassemia for different reasons. In beta thal, it compensates the lack of beta chains, and sickle cell, it acts as a very potent anti-sickling agent. And besides hydroxyurea, none of these are yet FDA approved then in practice, but epigenetic modifiers like histone deacetylase inhibitors or DNA methyltransferase inhibitors have been used in various studies, and then thalidomide derivatives. And there are ongoing studies, including at our center, and we're getting to start a study of an HDAC inhibitor with this compound, Novartis compound, shortly, we hope. So one modality of anti-sickling is by increasing hemoglobin. Of course, there are other modalities which we will talk about, either small molecule inhibitors of sickling or otherwise increasing the oxygen affinity of hemoglobin, which we will shortly talk to. Now, in this review published in 2018, Dr. Hebel, Dr. Ellen, and I tried to come up with certain therapeutic targets. The missing middle here refers to the middle of the cascade of events that lead to complications of sickle cell disease. Now, the initial point is the sickling, which I mentioned, and the end point is organ damage or pain. But if you remember this scheme that I showed earlier, there are so many events that contribute to this end, to the final picture, that one can't help but ask themselves, in addition to anti-sickling targeting the sickling phenomenon, can we target any of these phenomena meaningfully and make an impact on the course and expression of the disease? That has been a rather active area of investigation in the last 2 to 3 decades. Now, along these lines, I would like to first start with mentioning a novel therapy which was approved in the US in November of 2019. This is voxelotor, formerly called GBT440, a small molecule developed by Global Blood Therapeutics. That molecule works by binding the N-terminal of the alpha globin chain of the hemoglobin molecule. Thus, it increases the oxygen affinity of hemoglobin. And then when the hemoglobin S, sickling hemoglobin, does not relieve its oxygen, it does not polymerize. So the first phase 1 and 2 study was done in the UK, 38 patients with sickle cell disease treated for up to 6 months with different doses. The drug was well tolerated, no dose-limiting toxicities, and the patients showed a decrease in hemolysis by decreasing irreversible sickle cells, retic count, LDH, and bilirubin, markers of hemolysis. Now, this was followed by a phase 3 study of voxelotor, which was published in New England Journal of Medicine last August. This was a multi-center, multinational, double-blind, placebo-controlled trial in 12 countries, 274 sickle cell patients, mostly SS and S beta 0, but there are other genotypes too. In 12 countries, age ranging from 12 to 65, were randomized 1 to 3 arms, either voxelotor 1500, voxelotor 900, or placebo. And the endpoint of the study was an increase in hemoglobin over 1 gram per deciliter over 24 weeks. Now, very briefly, the results showed that more than half of the patients in the 1500 group reached the endpoint, as opposed to 7% in the placebo, which was very significant. In addition, 33% of the 900 group had a response, and In the 1500 group, there was a significant decrease in bilirubin, 29% decrease versus 3% in the placebo. Here you can see the hemoglobin response in different dosing groups. These are the so-called waterfall plots. In the voxelotor 1500 group, 59% reached the response. This was 38% in the, I must be doing something wrong and messing this up occasionally. And then 9% only in the placebo group. Here, you can see the tracing of the hemoglobin. The top green line is voxelotor, which had a mean average of 1.1. The 900 group had 0.6, and there was almost no change in the placebo group. This now shows the reticulocyte counts. There was a proportional decrease in reticulocyte counts, most pronounced in the 1500 group, shown in the bottom blue line, like you can see here, and 19% decrease, and the others were not significant. So this led to the approval of voxelotor with indication of increasing hemoglobin. Now, one might argue that since it's an anti-sickling agent, what about pain crisis? Well, that is still being looked into, and although there are some signal in the paper that there is a parallel decrease in pain crisis, this has not yet reached maturity, so that will be looked at later on. Now, parallel to that, there was an increasing interest in the role of adhesion in the pathogenesis of sickle cell disease. First pioneered by Bob Hebel in 1980, which showed that the adherence of sickle red cells to the cultured endothelium was a main mechanism. He further on went on to show that there was a correlation between the degree of adherence and the disease severity. In the following decades, there was intense research in looking at the mediators of this adhesion, which molecules played a role in this. In Steve Embury's lab, Matsui showed that P-selectin mediates that. This was later on confirmed by studies in Frenet lab at Mount Sinai, which in mice showed that P-selectin was the molecule that captured cells and then ultimately red cells that led to vaso-occlusion. And he further on went to show that P and E-selectin deficient mice were protected from vaso-occlusion. That was followed by several articles on P-selectin antagonism. One of that was a small molecule pentosine polysulfate. Although it showed some improvement in laboratory markers, since the endpoint was pain, it didn't reach enough power. Then there was a tinzaparin study from Saudi Arabia, was published in 2007, which showed that people who were admitted with sickle cell crisis were given either tinzaparin or placebo, and the tinzaparin group had a shorter period. And then finally, the crizanlizumab, which was recently approved, went into clinical trials. There were other studies. Pfizer developed a small molecule antagonist of all the selectins, which just completed the phase 3 trial, but unfortunately it did not show any effect on decreasing the period of the crisis. And there were some initial observations on the role of IVIG and beta-adrenergic blockade on blocking adhesion through different mechanisms. So the crizanlizumab study was developed by a small company called Celexis and was based upon the findings that P-selectin was the initiating adhesion molecule for sickle adhesion. And it leads to both leukocyte, red cell adhesion, and platelet adhesion. And the study was published, was a phase 2 study, multinational, was published in New England Journal of Medicine. And here I show the results. Basically, patients were randomized to 3 arms. Crizanlizumab 5 milligram per kilogram once a month after loading doses 2 weeks apart for 52 weeks, or 2.5 milligrams or placebo. The 2.5 milligram cohort did not show any significant effect, but here are the results, a comparison between 5 milligram and placebo. As you can see, median annual rate of sickle cell crisis was significantly down 45% with a p-value of 0.01. This is the most significant level of reduction in crisis since hydroxyurea. And then the other crisis-related parameters also showed similar improvements. Okay. Then, of course, the study showed that during the study, when they were receiving infusions of crizanlizumab, 35% of the patients remained crisis-free, as opposed to only 16% of those who were on placebo, and the 2.5 milligram was in between. So this also was approved in November of 2019 for the prevention of vaso-occlusive crisis in sickle cell. Before that, a year before that, L-glutamine was approved for sickle cell disease, and it was based on this phase 3 trial done in 230 patients, age range 5 to 58 years. And to not go over time too much, here are the results. There was a modest but statistically significant reduction. Placebo patients had 4 crises median. L-glutamine had 3 crises, and now we have these available. Now, I'll pass this. I'm sure Dr. Al-Zahari will be talking about that. And there are gene therapy approaches that are still ongoing, several different approaches. The one that has most data is the lentiviral therapy, and I will not be talking about that. But if you look at clinicaltrials.gov, there are 131 ongoing studies. 26 of them are drug studies, 37 transplant-related, and 18 gene therapy-related. So there's a wealth of studies, therapeutic studies going on in sickle cell disease, and I think that would lead to a significant improvement. Now, this is my final slide. So these developments lead us to think that, is it really time for combination therapy in sickle cell disease? And that could be considered in 2 different categories. Number one, can we combine different agents to induce hemoglobin F? Indeed, there is some data to support that. And then, of course, can we combine the anti-sickling therapies, treatments that target sickling, either F induction or others, with the downstream events that I tried to summarize somehow. So I think that the future is very important and interesting, and especially if you remember the map of distribution of sickle cell disease, some of these therapies, especially if they're in the form of a tablet, could easily be administered in resource-poor countries like Sub-Saharan Africa and India, and that would increase their availability. With that, I will stop here, and I thank for your attention.
Right. Thank you very much. Thank you very much, Prof, for sticking for the time. Really amazing talk, and thank you for enlightening us about the newer therapies. Now, before moving to the second lecture, I would like just to remind you all that we will have a room for question and answer after the end of the second talk. Please prepare your questions after the second lecture. Now, I would like to invite my dear colleague, Dr. Mohsen Zahrani, whom I really rarely see him. Actually, last time I saw him in the last ASH meeting, but I always bother him with my extremely complicated cases, both sickle cell and thalassemia. Dr. Zahrani is a consultant hematologist. He is head of adult hematology and cellular therapy at King Abdulaziz Medical City, Riyadh. He's a pioneer in stem cell transplant and sickle cell disease, and honestly, he's leading in this regard. Without any further delay, please, Dr. Mohsen, the floor is yours. Dr. Mohsen, do you hear me? Dr. Mohsen.
Assalamu alaikum.
Go ahead. Yes.
Thank you, Dr. Abdullah, for the introduction. It's a pleasure for me to join this webinar, and I would like to thank SSBMT for inviting me also. So my talk will be about bone marrow transplant for sickle cell disease. These are the objectives of my presentation. I will start with a case presentation. Mr. MT is a 19-year-old male from Yanbu, which is in the western area of the kingdom. He's a student in high school. He's no case of sickle cell anemia. He was referred for transplant. He had a history of stroke at the age of 14 years old. And since that time, he was treated with monthly transfusion and hydroxyurea. When he came, he had right side weakness. MRI brain showed multiple old infarct, left parietal, left temporal, and occipital lobes, and multiple old lacunar infarct, and also moya disease. So he is at very high risk of developing another stroke. We did the transplant for him in November 2015. He was one of the first few cases that we did transplant. We started the transplant program in our center in 2015. And we are using conditioning Cambath TBI as non-myeloablative conditioning. The donor was HLA matched related donor, his brother, and he is healthy, not carrier. And as you see, the labs here in the first visit, he had a hemoglobin of 98, and now with the last follow-up in September 2019, his hemoglobin almost super normal. He became sickle negative, and his hemoglobin is 0 because the donor was healthy. Really, the major change in his life is the quality of life. He was visiting hospital monthly to receive transfusion, but now since we did the transplant, he was never admitted to the hospital. No major complication, no GVHD, no recurrence of the stroke, no hospital admissions, his transplant, no blood transfusion. Once per year visit. Now we are seeing him in the annual visit clinic. This year he completed his college study. So this was a very encouraging case to pursue the transplant for other patients. As Dr. Abdullah Cutler mentioned, this is the map for sickle cell disease. It's the most common monogenic disease. More than 300,000 babies are born every year. In the Kingdom of Saudi Arabia, we have a large number of patients, estimated minimum of more than 60,000 patients, concentrated mainly in the Eastern Province and in the Western Province, especially Southwestern. Disease manifestations, typically most of the patients present with acute complications, and we have good treatments now that control the acute complications, but which also improve the survival of those patients. But what we see now, there is a shift in the presentation of patients, especially when they become adult. They present with end organ complications, even if they are responding to the preventive and other therapies. They present with like renal failure, liver disease, pulmonary hypertension, and other complications. Also, there is a well-known difference in the disease phenotype between different areas, and this can be related to different disease modifiers like the presence of genotype or haplotype. For example, the Arab Indian haplotype is associated with less severe complication compared with African haplotype. The high hemoglobin F is associated with less severe disease, co-inheritance of alpha thalassemia, and other environmental factors. Usually, the patients in this group, they are controlled with the conventional therapies, while patients in this group with more severe phenotype, they may need additional therapies such as de novo agents or bone marrow transplant or gene therapy. In Kingdom of Saudi Arabia, as we mentioned, most of the patients concentrated in the Eastern Province, and the majority of them, they have Arab Indian haplotype, which is associated with mild disease. Compared to the Southwestern region, they have African haplotype, which is associated with severe disease. And this is reflected in the referral for our transplant centers. Most of the cases, they come from the southeastern province. Treatment for sickle cell disease, the standard of care therapies, simple therapies, antibiotic prophylaxis, vaccination, blood transfusions, hydroxyurea. Really, these are the main therapeutic options that improve the survival and the complication of the disease. But we have also new agents, promising agents, but until now we don't know what will be the long-term outcome from these drugs. These drugs are not available, they are expensive at the current time, and they are not curative. In America, yes, we have drugs that improve the survival. Now the survival of sickle cell patients reaching the 4th or 5th decade, but rarely you have patients living above the 6th decade, and still the curve is less than normal population. So the allogeneic stem cell transplant can be curative. It's a potential curative option for sickle cell disease. And the first case that was reported in the literature that underwent transplant is a child from USA who had acute leukemia. He has also sickle cell disease, and he underwent stem cell transplant to cure the leukemia. And at the end, he was cured from the leukemia and from the sickle cell disease. The donor was his sibling, and he was a carrier. Despite that, he was cured from the disease. And this opened the era of the stem cell transplant for sickle cell disease, and subsequent multiple studies was conducted in this field. These are the common indications that we use for allogeneic stem cell transplant. Number one indication is the presence of CNS events like stroke, TIAs, silent infarct, and CNS vasculopathy, presence of recurrent acute chest syndrome, recurrent vascular necrosis, and recurrent vaso-occlusive crisis not responding to the best supportive treatment or best available treatment, which is hydroxyurea. A patient who is on regular red blood cell transfusion to control his disease, more than 8 transfusions per year, is also indicated this is a severe disease. Red cell aluminization, sickle nephropathy, sickle hepatopathy, recurrent priapism, and pulmonary hypertension. These are the 4 last items that are associated with high mortality rate. This is an elegant paper from a Saudi group in which they want to estimate how many, what's the percentage of sickle cell patients in Saudi Arabia who need a transplant. So they investigate 2 cohorts, one from Eastern Province and one from South Western Province, more than 370 patients. And they analyze them regarding the complications. And they took in consideration only 3 complications or indication for transplant: stroke, acute chest syndrome, recurrent VOCs not responding to hydroxyurea. And they estimated around 10,000 out of 60,000, 10,000 patients, they are fitting the criteria for indication for allogenic transplant. And really, this is more than what all transplant centers in Saudi Arabia can offer to these patients. So the demand for the transplant is high. This was one of the first few reported studies, multi-center studies about the role of allogenic transplant in sickle cell disease. It is multiple centers from Europe and USA, published in 1996, mostly children and with severe disease and were conditioned with myeloablative conditioning. With survival 91% and event-free survival 73%. So it was like a promising result. Subsequently, more studies, especially in children, was reported. And as you see, most of them reported survival more than 95%. And event-free survival also significantly improved, more above 90%, especially after the introduction of anti-thymocyte globulin in addition to PIOSI as a backbone for conditioning in most of the studies. So most of the studies in pediatric, they use myeloablative conditioning plus ATG. and with application of other supportive therapies, you can achieve more than 95% overall survival and more than 90% event-free survival. So the outcome in children, excellent outcome in pediatric population using myeloablative conditioning, low transplant-related mortality, low rate of GVHD and graft rejection. This is very acceptable to be applied to a children with severe disease. The drawback here is the high infertility rate and long-term adverse effects like GVHD and other secondary malignancy or other complications. So what about adult patients? Is the outcomes the same? Unfortunately, the outcome in adult sickle cell disease patients with allogeneic transplant is inferior to the outcome with in children. The reason behind that, when a sickle cell patient he became an adult, he accumulated organ damage. So there will be multiple organ dysfunction, and this will make them chemo intolerance to the liver, CNS, cardiac, respiratory, and renal. They will develop also sickle cell vasculopathy, increased risk of CNS bleed and stroke, multiple transfusion, increased risk of graft failure, impaired immunity, increased risk of infection. So how to improve this outcome? It's proposed to use to avoid myeloablative conditioning and try to use less intensity regimen like RIC regimen or non-myeloablative regimen. Use high stem cell dose to reduce the risk of graft failure. Avoid ABO mismatch donor if possible. And very important in the pre-transplant period is to optimize other parameters like keep platelet above 50 to reduce the risk of CNS bleed, keep hemoglobin above 9, aggressive control of blood pressure, aggressive control of magnesium and potassium, prophylactic antibiotic and anti-seizure medications. These are one of the largest reported retrospective studies, multiple registries from SSBMT, ABMT, and EURCORE of children and adults who underwent allogenic transplant with a median follow-up of 5 years. So 5 years, majority of patients are children, but there are few, around 150 patients adults, and the majority of patients here received myeloablative conditioning. 5-year event-free survival, 91%, 5-year overall survival, 92%. And it's very acceptable, 95% in children, but around 20% in adults, they died from the allogenic transplant in this retrospective study. So optimal conditioning regimen for adult patients to improve the overall survival, reduce the toxicity, and improve event-free survival is to avoid myeloablative conditioning. Use low toxicity, a protocol that is associated with low toxicity and morbidity, a protocol that is associated with long-term stability of myxed donor chimerism. In sickle cell disease, you don't want to achieve full donor chimerism is not essential. There are many reports where mixed chimerism is enough to control the disease and maintain adequate response. Low rate of GVHD, protocol that's associated with low rate of GVHD, and a protocol that allow for fertility preservation. We use this non-myeloablative conditioning that was invented by the NIH group. It is chemotherapy-free. They use alemtuzumab, which is anti-CD52 antibody, TBI 300, and sirolimus as all GVHD prophylaxis. They reported 95% overall survival and 88% disease-free survival. And multiple other centers, they reported same protocol or other reduced intensity conditioning protocol in adult with very promising overall survival, disease-free survival, and very low rate of GVHD and transplant-related mortality. So these are very promising studies in adult sickle cell patients. In our center, National Guard Health Affairs in Riyadh, we use the NIH protocol. We use only match-related donors. We give pre-transplant phase 3 months with hydroxyurea. The conditioning is with alemtuzumab or Cambath, total 1 milligram per kg, total BD radiation 300, and sirolimus for almost 1 year, for up to 1 year. And the source of the stem cell here is the peripheral blood stem cells from the donor. and the donor either healthy or carrier is acceptable. So so far we did 100 patients. This paper actually was accepted as oral abstract in the EBMT 2020. So 100 patients, the median age 28, majority were in hydroxyurea, and the majority they have mixed type of indications. Stroke was present in 26%. And the donor genotype is 50-50 between healthy and carrier. Graft failure, we have only 10 patients, which is 10% of the total group. But the post-transplant hemoglobin median was 12, and hemoglobin S 22%. Majority of patients maintain adequate myeloid chimerism and stable mixed lymphoid chimerism. Around 35% of patients were able to stop the immunosuppression after 1 year. The event-free survival, overall survival is 97%, event-free survival 85%. When we compare our result with our pediatric group, where they used myeloablative conditioning for their patients, their event-free survival 100%. For us, it was 92%. This was only with 49 patients. And the overall survival is very comparable between adult and pediatric, so very promising for both the adult group and for adult pediatric group. The majority of patients, they have low rate of admission post-transplant at day 100 and 1 year post-transplant, with admission more than 5 per year, 0, 3 to 5 very low rate, and 1 to 2 admission per year is very low rate. This is the hemoglobin value above transplant, around 120 median, and it was maintained at 1 year. Hemoglobin S also, it was reduced. Other groups, they reported similar outcome with the same protocol. This is from Chicago. They used the same protocol, alemtuzumab total body irradiation. Here they reported on 13 patients. All of them they engrafted, but also there was significant improvement in quality of life parameters and different parameters. And using this score is F60 parameters, pre and post transplant, there was significant improvement. And this is what we see in our patient group. King Faisal Specialist Hospital, they are using reduced toxicity regimen and excellent overall survival and event-free survival from their publication in 2015. So what about if no match-related donor? It's reported in USA the likelihood of 2 siblings being HLA identical is only 25%. And some of these siblings will have sickle cell disease. So this will be a significant limiting factor for allogenic transplant, is lack of the suitable donor. In our center, 57% of sickle cell anemia patients were found to have match-related donor. So around 43% of patients will need alternative donor. So sequence of alternative donors, if you don't have match-related donor in malignant condition like leukemia, lymphoma, the next choice is match-unrelated donor. The next one is haploidentical donor, then possible cord. But in sickle cell anemia, haploidentical donor is the second choice, and this was based on recent different publications showing that the haploidentical donor is associated with acceptable outcome. So for the match-unrelated donor, there was multiple retrospective studies showing a promising result, but this was the first prospective trial, BMT-CTN study, SCURT trial. It was phase 2 study. It was started from 2008 to 2014, around 30 patients for multiple centers in the USA with conditioning combat fludarabine, and 3 drugs was used for GVHD prophylaxis. As you see, the result here are not encouraging. Graft rejection 10%, acute GVHD 28%, chronic GVHD 62%, 38% extensive, 7 GVHD related deaths, and breast in 34%, with overall survival 79%, event-free survival 68%. So this study inhibit many of the centers to use the match-unrelated donor as the second choice for sickle cell transplant, allogenic transplant. There are many studies regarding haploidentical transplant in sickle cell disease. And as I mentioned, it is very promising, especially when you use the T-cell depletion either in vitro or in vivo. With in vivo T-cell depletion using the post-transplant cyclophosphamide, this was one of the studies, the Vanderbilt Consortium. It's the same as the Johns Hopkins platform, but they add ATG and thiotiba. And multiple centers shared patients in this trial with median follow-up of 13 months. The overall survival was 100%, and the 93% had more than 95% stable donor engraftment. This study is still ongoing. There are 2 centers from Kingdom Saudi Arabia joined this study. So we will hear after this study finish about the result. I will finish my presentation by another case presentation. This is a 31-year male from Jazan, case of sickle cell disease and sickle cell hepatopathy and liver cirrhosis, referred to us for stem cell transplant. He has frequent ER and hospital admission 3 to 4 times per year. He has recurrent hepatic sickling in the last 2 years before his presentation to us. His treatment was hydroxyurea, exchange transfusion, multiple times. When we saw him, he was deeply jaundiced, liver enlarged. He was showing signs of liver failure with flapping tumor, encephalopathy. We admitted him for transplant workup and to consult the hepatology for their opinion. So the MRI showed cirrhotic liver with signs of portal hypertension, ascites, pleural effusion. Workup for other cause of liver cirrhosis was negative. The hepatology evaluation, he had decompensated liver cirrhosis, child P, secondary to sickle cell disease. He's in catch 222 score, and there they mentioned he cannot have sickle cell transplant, stem cell transplant with advanced liver cirrhosis because he will decompensate with the chemotherapy and cannot have liver transplant with sickle cell disease. And the best option for him is to undergo double organ transplant, which is not performed in our center. Based on our experience with similar previous patients, we did use the non-male ablative regimen for those patients, and it was very successful. So he underwent allogenic transplant in May 2017 with match-related donor from his sister. Sorry, it was the transplant in May 2019. The conditioning came back TBI. The post-transplant course, good engraftment, liver function improved, no GVHD, no other complication. He had only 1 admission with febrile illness. He has significant improvement in his quality of life, no ER visit. He's back to his work. If you see his hemoglobin changed significantly from 55 to almost normal hemoglobin, LDH become normal. His bilirubin total was 826 and direct 639. Now it's almost normal. He's now having the hemoglobin S level of the carrier stage. And he was having very low albumin. Now it's normal or almost normal. So in conclusion, allogenic hematopoietic stem cell transplant is potentially a curative option in patients with sickle cell disease. Transplant in adult sickle cell disease patient is visible provided modification treatment regimen is followed. So in pediatric, myeloablative conditioning with either BioSci plus ATG is the standard of care. In our center, they use thiotiba, fludarabine, bisulfan, and they have excellent outcome, 100% overall survival and event-free survival. But in adult, you have to use less toxicity regimen or less intense regimen, either RIC or non-myeloablative regimen. Both regimen will be associated with low rate of complication, low GVHD, stable mixed chimerism, which will control the disease. Each high-risk patient deserves to be counseled or referred to transplant specialists to discuss pros and cons of the transplant. Thank you very much.
Thank you very much, Dr. Mohsen, for this elegant and informative lecture. Now we'll move to the Q&A mode now will be activated, so we can post your questions. Before we get the questions, I have 3 polls, so I want you to participate in this survey. The first poll is about the type of specialty of our attendees. So please, I want you to specify your specialty, adult hematology, pediatric hematopathology, pharmacy, nursing, or others. So we started to gather information now. We have like many of them are adult and pediatric hematology, but we have a lot of others. We cannot specify which others. Still, we are waiting for the rest to put their answers. So we have many others, probably they are allied health, I suppose, or maybe just general practitioner or so. We're waiting to complete the survey. Right. So we started to get also questions. So for the sake of the time, I'll move to the second vote. The second vote, I'll just show you the people who participated so far. So this is the result of the first vote. Now the second survey is about. I'll just close this one now. The second survey. 1 second. About a patient. If a patient is potentially a BMT candidate, would you prefer to proceed for BMT or wait for a few years, hoping that better new therapies, which may have better control on sickle cell disease? Could you please vote? So we started gathering votes now. People, I would rather proceed for BMT. Good. So this increases the awareness of the importance of BMT. Okay. Some people, they would like to wait for new therapies which may come in the pipelines. And some people are neutral. So they have either they don't have a clear-cut opinion or they don't know the right answer. Right. While we are collecting the poll data, I'll start with the questions. Right. The first question is to Prof. Abdullah Cutler. Has there been attempts at combination voxelotor and hydroxycarbamide or crizanlizumab and hydroxycarbamide? If yes, any safety signal or added benefit?
Thank you. That's an excellent question. Actually, in studies of both voxelotor and crizanlizumab, the patients who were enrolled were stratified for hydroxyurea use. In other words, a group was already on hydroxyurea and there were patients who were not. So I am not aware in any of the studies for any added toxicities. Now, again, after approval, hydroxyurea use, if somebody is on hydroxyurea already, that is permitted, and then the new drug can be added on it, be it voxelotor or crizanlizumab. Now, I can speak for the SUSTAIN study, the crizanlizumab, because we were involved with that. The patients who were not on hydroxyurea had a more significant reduction in their crisis with crizanlizumab compared to those who were on hydroxyurea, which I think can be interpreted as people who were on hydroxyurea already had a reduction in their crisis, but with crizanlizumab, they had a further reduction. But there were no added toxicities or no added side effects to my knowledge.
Great. I'll try to switch between you and Dr. Mohsen. So the question to Dr. Mohsen, like they're asking about how to refer how to refer a child with complicated sickle cell disease from Jeddah?
We can share our links to other centers through SSBMT or our colleague in the pediatric, Dr. Muhammad Isa and his group, they are accepting a referral through the system of National Guard. So if you go to the National Guard website, there will be a link where you can refer your case through the eligibility office, and it will reach to the service requested. We will screen the cases, and we will accept the case. Then we will contact the patient for the appointment.
Right. The second question to Prof. Cutler. Dr. Munir Bakshi is asking, your combination therapy is very expensive. What is your reply?
Well, all of these therapies are expensive except for hydroxyurea, but that's not unmanageable. Even in the United States, where the health insurance and healthcare system is not that widespread, as you all know, companies have put in place mechanisms to cover for that. In other words, if you have a patient in the United States who you want to put either on voxelotor or crizanlizumab in addition to hydroxyurea, that can be done. Well, there are some hurdles that you need to get over, but both companies who market these drugs have developed mechanisms to help with those patients. So it can be done, but it's not cheap.
Right. Okay, Dr. Zahrani, the question is, what is preventing the pediatric group of using REC in transplant?
I mean, the excellent outcome from myeloablative conditioning, more than 95% overall survivor and even free survivor, is very encouraging. And this is a standard of care. Either use Biocide plus ATG. In our center, as I mentioned, they use Taytiba, fludarabine, Basilfan, 100% survival. So it's very encouraging result. The only problem is the risk of infertility and long-term complication from the transplant. I think there is clinical trials trying to address the use of reduced intensity or non-myeloablative conditioning in pediatric, and to see the outcome using this regimen in pediatric. The only thing you will get worried is the risk of graft failure. When you use the non-myeloablative or reduced intensity, the risk of graft failure will start to appear compared to myeloablative conditioning. However, in Alberta in Canada, they use the same protocol, CAMBATH TBI, and they reported their result, which is also excellent outcome. And some centers start to adopt this protocols. So you can discuss with the family. If the family, they are worried about the infertility, risk of long-term complications, and they are accepting the low risk of graft failure, then you can go ahead with the reduced intensity or non-myeloablative conditioning.
Right, because we're running short of time, we'll try to use the ping pong style. Prof. Cutler, if you can make your answer as concise as possible. So the question is for you. All studies have been done for crizanlizumab and voxelotor were unfair for hydroxyurea user patients. They include the placebo hydroxyurea and non-hydroxyurea user patients. Still, those studies are shaky. And in addition to short run side effects is more worse than hydroxyurea. What's your comment?
Clear as to now, but in both studies, the number of patients on hydroxyurea and who were not on hydroxyurea were balanced. So it wasn't lopsided. And I don't think that we have any evidence that the side effects between those who were on hydroxyurea or not on hydroxyurea are any different. And overall, they were all very well-tolerated studies, I think.
Right. Dr. Mahsen, question about, do you place sickle cell hepatopathy, cirrhosis, as indication for stem cell transplant, like your last case in your presentation, Dr. Hussein Said is asking?
Yes, I think, and this is why I presented this case. those cases, they are missed, and if you don't do transplant for them, they will die from the sickle hepatopathy. It's very bad complication, rapidly progressive. We lost 3 patients before we implement the transplant from rapid progression to fulminant liver failure. And the liver surgeons, they will not do transplant for them because the sickle cell disease is excluded from their, is an exclusion for the transplant. While doing non-myeloablative conditioning, this is the trick. You should not expose them to chemotherapy because they will decompensate to liver failure. But we use this protocol, non-myeloablative, so far in 5 patients, all of them with very advanced liver failure. Like this patient, he was encephalopathic. It's tolerated very well. It went smooth with no complications. And all of them, they have reversal of the liver function. They are back to almost normal liver function.
Amazing.
So those cases, I'm sure there are cases like this patient in the kingdom. Please, those patients need rapid referral to transplant center.
Okay. Quick, Prof. Cutler, is there any role for vasodilator like glutamine?
Well, I mean, I mentioned briefly L-glutamine, and the difference between L-glutamine and placebo was very small in terms of preventing crisis. But it's approved, and we have prescribed to some patients. I don't know how the post-registration or post-approval data is. I hope the company is collecting that. But it doesn't seem to have been used that frequently for a variety of reasons.
Right. Dr. Zahrani, best age for BMT and sickle cell disease?
So it is a controversial question, especially in a pediatric group, because if the patient show early complication, that's an easy question. But if the patient is not showing the full phenotype of the disease at the pediatric age, it's controversial to transplant or not. When the patient reach the adult age, at that time we will know very clearly the patient is in very severe phenotype or in mild phenotype. So at that time, the decision is easy to do transplant or not. The best age is for sure in the pediatric age, because the patient still did not accumulate organ toxicities or organ damage, so he can tolerate the transplant conditioning with low toxicity. But as I mentioned, even in adult patient, this was a concern. But now using non-myeloablative, reduced intensity or reduced toxicity conditioning, it still can be done with excellent outcome.
Right. Prof. Cutler, Dr. Ahmed Lasker is asking, and I think this will be my last poll later on. He is asking, in view of the presence of curative modality with over 90% success, what do you see the prospect of the current novel agents?
Well, I think that's a very good question. Of course, and Dr. Zahrani said, those who have a suitable donor should go ahead and have a donor. There are 2 obstacles. Number one, although the donor availability is increasing with haploidentical transplants and everything, which is a very welcome development, still, this is a high-tech, high-resource demanding process. And if you consider that the bulk of the patients are in under-resourced areas like in Africa or India, so we still need these therapies that could be administered easily. So I think that the research and application of therapies will continue on both fronts, in the transplant and gene therapy front, as well as in devising simple oral therapies that target any of the mechanisms that are likely to have an impact on sickle cell.
Great. So, Dr. Mohsen, what is the long-term prognosis for BMT in both adult and pediatrics?
We have now, especially in pediatric group, the transplant is already done now for more than 20 years. So I can say it is excellent, the long-term outcome. We are not sure if those patients will reach normal life like other healthy population regarding the age. But it's expected if you cure the patient, you will reduce the complications and you will reduce the risk of dying from the complications. So this will come with time, like after 10 years, 20 years, or 30 years with long-term follow-up of those transplanted patients. But I can say at least from short follow-up, 5 years, 10 years, it is excellent with significant control of the disease. And the most important factor is the improvement of quality of life in those patients.
Now, Prof. Cutler, Dr. Shakir Sadadi is asking, what are the safety profile in pregnancy of the new novel agents? We know that hydroxyurea should be discontinued in pregnancy. I have conservation on this because we have more than 85 babies born with the pregnant lady who were using hydroxyurea in Qatif Central.
Right.
So, Prof.
Couple of quick points. It's an excellent question. I don't think we know the answer to that, but if I have to guess, I would probably say that crizanlizumab would likely to be safer in pregnancy than voxelotor, although we don't have any evidence that it's teratogenic. We don't know that. Now, hydroxyurea, I agree with you, Dr. Al-Zayed, that we have had many babies born on hydroxyurea, and there recently has been a tendency to consider the use of hydroxyurea, at least after the first trimester, in pregnancies who are very severe with frequent pain crisis or acute chest syndrome. So that's a changing and evolving subject.
Right. Dr. Mohsen, is gene therapy less intensive than allo stem cell transplant? And do you see gene therapy overtaking the allo transplant sickle cell disease? If not, what are the obstacles, availability, and cost? This is a very long question. If you can concisely answer it, Dr. Mohsen.
So gene therapy still, you need to give conditioning. It's like autologous transplant, but with gene therapy, you will not see graft versus host disease or other complication from allogenic transplant. It is promising therapy. It's too early to see the long-term effect of the gene therapy. At current stage, is performed in limited centers. It's very expensive, so we cannot decide now for gene therapy.
Right. Prof. Cutler, any drug interaction with hydroxyurea in the studies with the novel therapies?
No, nothing has been recorded. I think since they all have different mechanisms of action, there have not been any specific adverse interactions between hydroxyurea and the new drugs in these studies.
Okay, Dr. Mohsen, how much is the highest hemoglobin S should be before transplant in your National Guard protocol?
So before we start the conditioning regimen, we do exchange transfusion 1 or 2 sessions to bring the hemoglobin S less than 30, only to reduce the pre-transplant complication from the sickle cell disease and sickling complications.
Right. I think I have to stop here. Before we stop, I'll ask you the last question. As per Joel Barker, who is a futurist, they has a rule called back to zero, and when a paradigm shift happens, everyone goes back to zero. So when there is a paradigm shift, it tends to be accompanied by a large negative return, i.e. there will be other parameters which would be negatively influenced. So my question to both our speaker, in your expectation with the current ongoing therapeutic development, which therapy will be negatively affected? And I would like also to take the opinion of the audience in this term. So Prof. Cutler, what do you think?
Well, I mean, at the present time, I don't think any of these therapies would be negatively impacted. Bone marrow transplant is curative and it's increasing. Hydroxyurea is time-honored, and we're using these in combination with that. Transfusion has very specific indications. We can use it for that. But I think if we can decrease transfusions by increasing hemoglobin with voxelotor, for example, that would be an advantage. I mean, if I have to say, I would say maybe we can decrease transfusions with these new therapies.
Right. And Dr. Mohsen?
I agree with Prof. Cutler. I think we need all these options. Until now, still the options of therapy for sickle cell disease is limited. Some patients, they are well controlled with hydroxyurea. I have many patients in my clinic, they are well controlled with hydroxyurea. I don't advise them for transplant. Some patients, they need transplant to control the disease or to cure the disease. And we need also transfusions in pre-transplant or just to prevent other complications. Novel agent is also needed, and we need to work more to develop more novel agents.
Thanks. So before we wrap up our activity, I would like to express my gratitude and acknowledgement to both distinguished speakers for sharing their expertise with us. Thank you, Prof. Cutler, and thank you, Dr. Mohsen. It was really interesting, fruitful, and informative lectures. Thank you to the Saudi Society of Blood and Marrow Transplant, and a special thanks to Novartis for sponsoring this event. So enjoy the rest of the night, enjoy the last third of Ramadan, the last 10 days with God blesses, and Eid Mubarak in advance. Thank you, and bye.
If I also like to my gratitude to the Society of Bone Marrow Transplant. Excellent talk, excellent update, Dr. Zahrani, and you did an excellent job as the moderator. And I would also thank all the participants for excellent questions. That was a terrific session. Thank you very much.
Thank you very much, and have a nice.
Thank you, Dr. Abdullah, Dr. Cutler. Thank you. I just posted our emails, the adult and pediatric transplant program, for anyone who wants to communicate with us or refer cases.
Great. That's very great. Thank you very much, and have a nice night. Bye now.
Thank you.